Welcome to That's Derm Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Welcome to That's Derm Good. Today, my guest is Leigh Ann Pansch. Leigh Ann is a nurse practitioner in dermatology. So welcome, Leigh Ann. Thank you for joining me.
Thank you for having me. Excited to be here.
Yes. So I always love just to hear, everybody's background is so different. I feel like not everybody is like, that's my goal to be in dermatology. A lot of times it's like, I want to get into healthcare and I want to go this route. And then it turns you in a different way. I love to know like what drew you into the healthcare space and into dermatology specifically becoming your specialty.
Goodness, my story is very unique. I will say that. When I was 5 years old, I had to have my tonsils out and I was terrified of needles. And my mom told a story that I went in bucking and screaming. And there was this incredible nurse who looked me in the eye and told me everything that was going to happen and waited for me to say, okay. After that experience, I wanted to be, and I knew I wanted to be a nurse when I was 5. And so I went to nursing school in Northern Kentucky at a school called Thomas More University. And I graduated with my BSN. And I went to work mostly mamas and babies. So I started out in a level 3 NICU, the littlest of the littles. And I spent a couple of years there and then met my husband and we started thinking about having a family. And so I knew that I needed to get out of critical care because it was not good for my mental health. And so I went to learn labor and delivery, and I spent 1997 until 2010 in L&D and brought a special care nursery up from a level 1 to a level 2. And just really enjoyed that experience. I really learned that I like chronic care. And I learned that I really enjoy education because we got to educate every single family that was leaving. And I learned that I really love it when my patients are, for the most part, healthy. That's where I'm the healthiest mentally. And so when I went into grad school in 2008, I just assumed that I would be at Cincinnati Children's Hospital, which is where I had spent my entire career teaching. And I started teaching along the way too. I guess I should have said that. And long story short, my very last semester of grad school, my dad was terminal. And so when I recognized that, I just decided I better finish school and spend as much time as I could with him. And I finished grad school on March the 15th of 2010, and my dad died the 31st. I like to think that he had a little something to do with me landing in dermatology because I couldn't be more happy. Again, I get chronic care and I get to help people feel good about the way they look. And inflammatory skin disease just drives my brain in a way that I can't explain. I'm just fascinated by the human body. And so my dad died and I obviously had some grieving to do, but I went on a bunch of interviews and I took the best job and it was the dermatology job. I think I had about 7 offers and it's a different time then. I know it's really hard for people that want to get into dermatology now. And I would say one of my proudest accomplishments as an NP in dermatology, I am the clinical director of education for Docs Dermatology. We're in about 11 states. And as of last year, we started our own NPPA fellowship program.
Wow.
So we are about to start cohort 2 this July, and very excited that our first cohort of 6 are thriving in their locations with the preceptors that they've spent time learning from. And then I do didactic virtually so we can all join in.
That's amazing. Do you feel like your time, your background across, pediatrics and women's health and education, how do you feel those experiences shape the way that you practice dermatology today?
Such a good question. I used to brag when I worked in L&D that we were everything nursing. We were OR, we were ER, we were floor nursing, we were peds, we were um, uh, acute care, if you will, all of these things. And so I definitely love um, like what's going to come through the door kind of thing. And I would say it's really amazing when you learn just simple things like what labs do you order for this disease? How physical therapy might play into certain aspects of patients and patient care. You learn from just experiencing it with patients along the years. And yes, everything transfers, everything builds together in such a great cohesive way. It's crazy that things that I was learning and doing, even 20, 25 years ago still matter and still are things that, we talk about and certainly certain patients of mine have to deal with.
Yeah, absolutely. My sister-in-law is an RN, and I feel like all the RNs that I talk to, they all wanna be in labor and delivery or with pediatrics with the babies. It seems like one of the most critical times and just so, I think, important. It draws everybody in, I'm sure because of the babies, but at the same time, you're seeing so many different things, and now I'm sure you still probably get to treat a lot of the pediatrics and the derm side because we see so many chronic conditions happening, unfortunately, in some of these babies and young children as well.
Absolutely. Just to recognize that pediatric dermatology is its own specialty. Mm. I've said for years that dermatology is the foreign language of medicine. We start with these crazy descriptor words and then we have descriptor phrases, and those phrases are tied to various morphologies. So you have to learn that language before you can really practice and practice well. Pediatric dermatology is a whole nother specialty. And bottom line is they're not just little adults. They have, a lot more of the genodermatoses, and you have to think more syndromic when you think about kids. They are complicated for many reasons, be it family situations, or maybe they have an organ transplant and they're chronically immune suppressed. There's a lot of things that really factor, and you have to understand that your visit and your care of them is you do it best when you play a game with them, when you incorporate play with them to kind of gain their permission and wait for their cues.
Yeah. I don't think I actually realized that pediatric dermatology was like a different specialty. I thought dermatology was just all dermatology.
Yep, the Society for Pediatric Dermatology is aside from the AAD, and they actually, at least on the physician side, you can become a fellow of the Society for Pediatric Derm, and it's a whole extra residency or fellowship.
So you were also the first nurse to hold a joint faculty appointment at Cincinnati Children's. What did that role teach you about leadership and innovation and care?
At the time, I was working for the University of Cincinnati College of Nursing, and I was teaching a bunch of traditional and accelerated students doing clinicals in mamas and babies in labor and delivery and in pediatric settings, because that was really my background as a nurse. And I was approached by a unit where I had had a lot of students. It happened to be a GI unit at Cincinnati Children's, and it was the end of my second year. So I had been there for a lot, at least 2 years. And they knew me and they knew my students, and they hired 11 of my graduate students to work on this unit. And at the same time, their education specialist, the person that was going to be really responsible for their orientation and sort of all the checks in the box with schedules and what all you have to complete in an orientation to work at Cincinnati Children's, she was going on a maternity leave. And so they said, you know what? It's summer for you. Can we hire you to do this role? And I thought, why not? Seems reasonable. I know everyone. This seems, these are my students. And they said, you can just focus on your 11 students. And I thought, wow, I couldn't think of a better thing to do over the summer. And
Yeah.
so that's how I started working at Cincinnati Children's in education. And at the end of the summer, I had a conversation in a committee meeting with the VP over the Center for Professional Excellence. They were starting a fellowship program for traditional baccalaureate nursing students in their last year. So it's going to start in the summer after their junior year, where they would be one-on-one with a nurse at Cincinnati Children's in a unit, and then essentially get all of their core metrics, all of their orientations done on a student salary that summer. And then at the end of that year, all 15 of my students actually went to work at Cincinnati Children's and hit the ground running in those units because they had spent a year immersed in those departments working one-on-one with a nurse preceptor. And then 3 years later and 5 years later, we had very low turnover. And in fact, some of my former students started precepting other students. And so I would say it was my first opportunity to really sort of see the bottom to the top in functioning in a large academic medical center. How do we identify gaps, specifically, the gap from education to practice? You could talk about as a nurse, you could talk about it as a derm NP or a PA, what we learn in practice in school, and then what we need to know to be able to practice effectively and efficiently and safely in the clinical setting is very, very vastly different.
It's really interesting. I mean, that definitely hits a lot of points that I think it can be difficult. You can learn everything you know, you could be book smart, but being able to actually implement that in real life is totally different. So how do you bridge that gap with what they've learned to actually applying that in real life and working with real patients?
Yeah, great question. So, two answers. First is I think if you're going to choose dermatology, if you're going to choose any specialty, if you want to practice well, you learn to sort of recognize when you don't know something. And instead of giving into that fear of, oh my gosh, I don't know, you transform it into a drive. I'm going to learn everything about this diagnosis that makes me super uncomfortable. And then before long, you start building on that knowledge and then you become an expert. Really, because you
Mhm.
start looking for that in practice and people start coming to you and saying, hey, can you tell me about this disease or that disease? And then once you're done there, you're in practice tomorrow and you see another diagnosis that you're just, ooh, I don't know, something is wrong. Let me go get another set of eyes. Let me bring them in. Let me, see what they think. And then before long, when you practice long enough, you start to be the person that people pull you in the room and you get to validate that, hey, that was a really interesting and unusual presentation. And it could be this, but it could be this. So I think just learning to recognize that fear of I don't know, but to use it as a drive. If you choose dermatology, choose to be a lifelong learner. So that's one. The other is, the Society for Derm Physician Associates and the Center for Dermatology Nurse Practitioner Practice. They have two, they're called blueprints, but all of it is evidence based. In fact, on the NP side, my pal, Dr. Margaret Babanich, who also is from OH,
IO.
thank you. She's from Cleveland, and she actually, her doctoral project was coming up with the blueprints for NPs on the NP side. So there are two blueprints put out by those governing bodies on what as an NP and what as a PA you need to be certified in dermatology. And when you lay them on top of each other, they're almost mirror images. There's
Hmm.
so much commonality surrounding things like dermatoses. Like, for instance, about 20% of the exams are eczematous dermatoses. I don't think that should shock any of us. We see the majority of eczematous dermatoses by number, by volume. If you look at those and kind of use those as a map on this is what you need to know to be an expert, then you can teach to those, even the newbies, and make sure that they have everything they need to be in practice. All while, at least at docs, I'm doing didactics on those topics, but then they're being immersed in the clinic with a clinical person who's a peer but then, they develop this lifelong relationship with, aside from their
Yeah.
collaborator.
One of the things that I really heard loud was you have to be okay with not knowing something and be willing to find out. I think so many people get stuck on the fact that, oh, I don't know the answer. And then they're hung up on that. And that's a hard thing to do. But being able to pivot from that and say, okay, you know what? I don't know the answer. Admitting that you don't know the answer, I think, is the big step. But being able to go and learn and figure out, okay, what do I need to know? And how can I figure out everything that I need to know about this so that I don't run into that situation again?
Absolutely.
So I saw your LinkedIn post and I got really excited when I saw this post. Um, just asking providers what they prescribe off label. What inspired you to, number one, ask that question? But I now tell you a little bit of like why it excited me. On my end, I see the access side, and I've got a team of coordinators. They're always like, the stock wrote this off label and I need help trying to figure out how do I get this approved. And it's a big struggle. I like to follow a lot of the clinical studies and things like that. But I think that is one of the challenges as a biologic coordinator and our access teams, figuring out, okay, how do I work with my providers when they do like to write a lot of things that are off label? What are some things that we need to know and how can we manage that? But back to that question, what inspired you to ask that question?
I think at this stage of my career, coming up on, my second decade, it's the nuances that just really I find very interesting. One of my favorite things to do is to sit in a group with other experienced dermatology providers and talk about a problem and how do you fix it? How do you treat it? What are your pearls that you can share with us? I get so much from learning from others at this stage and, as well as our patients that come through the door. So that's the one thing. And that's really what made me, I was trying to come up with something that people might engage with, just because I think for so long, you can get kind of just in the scroll mode on LinkedIn, but I really wanted some engagement. And I think I got it with some really great recommendations and some that I've used and some that I'm waiting to try. I think one of the things that's really, really important is to sort of differentiate the role of MPPA versus MDDO. And realistically, from a legal standpoint, you need to know your state laws surrounding prescribing practices. I can tell you in Ohio, at least I have the ability, as long as it is within my scope of practice, to prescribe something. But if I'm prescribing something off label, I really am very passionate about the fact that I put the reason why I'm
Mm.
using this off label. And, little did I know that now my bio coordinator is looking at my medical note and seeing my clinical reasoning and rationale behind using it. One of the most recent examples, I did not need a bio coordinator to do it because it was a generic medication, but I had a patient who had systemic granuloma annulare and her son was getting married and she really wanted her systemic GA to just look better. And so we talked about risks and benefits. Granuloma annulare is, unfortunately, there was no FDA-approved drug to treat it. And we had sort of tried everything else, but she was so much widespread that we knew we needed a systemic medication. And so I called my buddy who practices at my practice, Dr. Matt Zyrus. And Dr. Zyrus, affectionately, I call him Cowboy. He said, why don't you try oral roflumilast, which is an oral generic PDE4 inhibitor. So kind of like an oral Zoryve or an oral crisaborole or Eucrisa. And so we talked about it with the patient and she was amenable and she was a great patient because she was otherwise healthy. And she actually did about 90 days of therapy, enough for her to go to her son's wedding and not have anything showing. Or I think she had a little area of hyperpigmentation on her elbows that she was able to cosmetically cover with a good old spray tan. And she was beyond thrilled. And so I think circumstances like this, where there really isn't anything, or where you've tried everything, or there's a reason to not try something, it puts you in a little bit of a pickle or a conundrum clinically. And you want to know, well, what are other people doing?
Do you think dermatology relies on a lot of off-label use compared to other specialties?
I would say yes. Starting from my days at Cincinnati Children's and Derm, pretty much everything in kids and until the last 5 or 6 years has been off label. Think about it. Topical steroids, antibiotics for acne. No one studied this in kids. So everything is off label there. If you think about topical corticosteroids in general and what studies have actually been done and what data do we actually have, it'll terrify you. But yeah, we probably all should know that. But yeah, there's a lot of off-label therapies that we use, methotrexate, cyclosporin. None of this is approved for use, but many of them are the standard of care. Acitretin for some of the more severe papulosquamous eruptions. The good news is those are all inexpensive therapies, but that you might not need a biocoordinator for. But there are circumstances where we really have to get on the phone with an insurance company, or I've over the course of my career, I've had a couple instances with some adolescents who had really severe HS, who needed a therapy before there was an approval. And in some circumstances, I was able to contact the company and through their medical arm, get the patient access to free drug,
Mm,
which is great for us to know as providers too, that resource is sometimes there for these
yeah.
pharmaceutical companies.
So when it comes to deciding what you're going to use that's off label, how is that balance, the evidence, the experience, if it's not an FDA approved indication, what are you looking at clinically, or what are most providers looking at to make that decision, or to see, do you connect with the manufacturers to hear about their clinical trials? How does that work?
Yeah, I think you really have to have a good understanding of the disease, of the pathway of the disease to start. Uh, there are certain nuances with patients. Maybe they've had a history of a solid tumor, or they're chronically immune suppressed because they have a kidney transplant. And there are various reasons, maybe a patient who has some degree of liver failure at baseline because of non alcoholic fatty liver disease, or just knowing your patient and knowing the pathway, I think is where you start. And then, at this stage of my career, one of the joys when I'm having conversations with patients is really to talk about treating their disease in terms of a shared decision. And so at the end of the visit, I often sit down or I step back and I lean up against the wall and let them know that I'm here. And now's your time to really decide what's best. And here are the options that I see, starting with not treating, which I'm a big fan of throwing that out there to patients. But I also stress that in certain circumstances, under treatment can actually put you at greater risk. And my classic example is a patient with moderate to severe AD who we're not treating. Suddenly you're at risk. You could be at risk for infection that could really kill you. And so not treating is an option. We could go to a topical therapy, but we've tried that. We've maxed this out. You are able to use this and you see benefit, but when you stop it, you flare immediately. That's not good disease control. That's not utilizing our topical corticosteroids the way that we would like to utilize them. And so we really then could talk about maybe a non-steroidal topically. And then beyond that, we're looking at systemic agents. And some of those medicines are oral and some of those medicines are injectables. And then there's the oldies, but the goodies. And in order for me to sort of assess if we want to talk about treating this medicine from the inside out, I need to ask a few more questions about your history. That's
Yeah.
usually how I do it.
There's so many other medications now. Do you think that because they've been written off label, they've inspired these manufacturers to do clinical studies because they see it might actually work for this as well. So let's start those clinical studies to get those going so we can get that approved.
Absolutely. Classically, that is a real thing. I think about dupilumab for prurigo nodularis. Patients had AD and prurigo, and guess what? They both improved. And that's such a fascinating conversation because we used to think that prurigo belonged in the type 1 inflammatory spectrum with psoriasis and the other hyperkeratotic disorders. But the fact that they improved and their itch improved and then their nodules improved by treating them with dupilumab, the company scratching their heads like, maybe we need to look into this. And sure enough, they got approval. And the same is true for bullous pemphigoid. But that's such a nuanced disease with a very complicated immunologic picture, a little bit of a mixed, if you will, picture inflammatory pathway wise, but dupilumab works. And I'll tell you a really funny story. I got a hand me down patient from one of our providers, incredible providers, very experienced up north. There was a patient of hers who had been treated for scabies 14 times in 12 months. And she had biopsied her and it revealed spongiatic dermatitis, which is kind of that like all encompassing term. Like that's what you hate to see. So she comes to see me because her family, they were putting her in like an extended living facility. And the very first time they came in, her son, who is her power of attorney, he just had this angst about him. For starters, he didn't want to be anywhere near touching his mom because of the whole scabies thing. I think that it had gone in his head and he couldn't explain why she was scratching all the time and so itchy, and she couldn't explain it. So long story short, at that moment, at that visit, I said, I really think that we should talk about dupilumab as a potential treatment for you. And they were all on board. And I didn't, I was very clear that, I'm not really sure that it would help, but it might. This is clearly not scabies today. I can tell you that. I can't go back and tell you that it wasn't before, but I can tell you we got to stop this crazy cycle. And you're really itchy and your rash shows that this drug may help. And so they were all on board. We got it approved and they came back into my office for injection training 2 weeks later. Okay. And so at this visit, I pulled her shirt off to like talk about the places that you can give this injection. And what do you know? Her entire arm is covered in bulla. And so I'm looking at this and I'm looking at him and I just said, time out. I understand that we have this approval for dupilumab. We're going to do that today. Actually, they were in pipeline. They were in study. We were doing some of their studies up north and in our offices. I said, so I can't promise it'll help, but it might. And they were all over it. And in fact, the son, he was so openly hostile when I told him, I think that we need to do some more biopsies today, just to confirm that you have bullous pemphigoid. And I was trying to explain a little bit about that, but he had been through just a year of people telling him in the healthcare industry that it was this and it was this. And then he had come to see me and I said, we have a plan. And so he didn't want anything to jeopardize his mom getting that dupilumab injection. It's exactly what we did. I went and consulted with one of my collaborators and we said, you know what, let's do it. Let's try it. And when I saw her back 2 weeks later, he was sitting there holding his mom's hand.
Wow.
And so, yeah, you got to know your pipeline. You got to know your pathway. But I'm going to tell you, it was incredibly rewarding to actually see the improvement in her skin and in their relationship, and certainly with reduction in itch. And she's still a patient.
That's amazing. I mean, it just goes to show that understanding that collaboration with the other prescribers is huge. You're giving hope to patients versus just saying, well, we don't have anything approved for this. Sorry, let's think of the next option. Yeah, it's so important to be able to do that, and having that option available for patients, it makes a huge impact on their quality of life, their relationships. That's amazing.
It's a great job.
Yeah.
Love it.
That is so good. What about, like, some of these, I wanna say, like, not newer conditions, because, like, alopecia has been around, or vitiligo has been around for a long time, but it's just now starting to have, like, actual medicines, that are FDA approved for patients. I remember for the longest, we would try to get Xeljanz approved for alopecia, and
Yeah.
it would be so difficult. What are some of the things that you think are important when it comes to trying to work with insurances to get stuff approved, but just like working with the team, with your medical assistants, to make sure that, we have that documentation that shows, I think they're probably, correct me if I'm wrong, if there were clinical trials on Xeljanz for alopecia. I feel like there were, and we were trying to pull some of those things.
More case report and smaller studies, but yes.
Yeah. So what do you think that looks like with the access team, when they're trying to get stuff approved? What are the
Yeah.
important things that you see is needed to document, but also what questions should your medical staff be asking if they need more information?
Yeah, these are great questions. And I think first and foremost, knowing your label. So, when you talk about alopecia, what type of alopecia? Alopecia areata. In this instance, we actually have three approved systemic agents. And knowing that this is now severe disease that we're treating per label, we're not in the moderate to severe category with alopecia areata. We're in the severe category. Wanting to catch severe disease, but then catch them before they get to very severe disease because they have poorer response to systemic therapy if they have very severe disease. And then feeling comfortable with the box warning surrounding the Janus kinase category of therapies, which most of these therapies are in, and then some little nuances there with ads in terms of mechanism of action. But know your label. So, what I mean by that is there are easy ways to sort of code that they have severe disease in the world of alopecia or in the world of AD. If you're noting that they have moderate disease, use your IGA, put your IGA in. So that you can classify in some way that they have moderate disease with AD or severe disease in the case of alopecia areata, which is what our label is. You wouldn't want to say that they have, I might associate, even though we would split hairs and say that this patient has alopecia totalis or alopecia universalis. I would often, because the label is for alopecia areata, I would say alopecia areata and I would associate alopecia totalis or alopecia universalis. That way, there's no confusion that I'm actually using it for the approved diagnosis. The same could be true in the world of atopic dermatitis. If you have a patient that has maybe nummular eczema or contact dermatitis, I would use atopic dermatitis because that's the umbrella term that all of these diagnoses fall under. And that's what is on the label in the package insert. And so know that package insert and know what language in terms of the who this is for. And so with alopecia, I'm going to make a note that you have severe disease. I'm likely going to include a SALT score, which is the measurement for alopecia. And I always think about when I was a kid and we played that game called Headbands. Do you remember that Headbands game with like card and you didn't know what it said and you'd have to get like tricks, that little headband thing? I always felt like if we could create some sort of headband that would like divide their head into sections, that would give us a really realistic SALT score. But you can look at a patient's scalp and you can kind of section it off and decide how much hair that they've lost based upon those sections. And then if the patient has progression toward universalis, which just simply means off scalp, so if they've got other areas of hair loss, they're really in that severe category already. So knowing that is easy to sort of put that data in. And that way, at least when you're going to the pharmacy or to the insurance company and saying, would you please cover this therapy? It makes sense to them why you're asking.
Right.
In terms of working with your team, you know, I'm a big, huge advocate for just the team in general. I always tell my team, you're my right hand and my left hand. I work with three amazing MAs, and one of them functions as my bio coordinator. And I have to say, I can't do my job well without them. I really don't even want to try. But there are some fun things that I've learned over the years. So I know their favorite candies. They're in my work bag at all time. I usually throw in some Starbucks gift cards or whatever, gas gift cards. I throw in things that like matter to them in my work bag. And we have this little game called Best Chief Complaint. And so, we make a game out of who's got the best chief complaint. And usually we'll enthrone it in a little notebook. We don't put any patient names in there or identifiers, but it's just hilarious what people say that really helps get at overall life quality. For instance, we had a patient with severe AD who came into the office and said, if you don't help me, I'm going to kill myself. And that was his chief complaint. He needed help immediately, and we needed to act accordingly and hastily, amongst other things. But that said, working with your team and making a game out of it, one of my very favorite questions to include in the history of the present illness, and your team can very well ask this if they're scribing, is you can say, what is it? And this is my friend Douglas DiRuggiero. He's a PA, quite a famous from Rome, Georgia. He says, what is it that you're not doing that you want to do more of if we could get this disease better?
Hmm.
And then put that in the HPI. And when you see them back at their follow up visit, ask them if they're able to do what they weren't doing, that they wanted to do. That's the real measure. But those are the kinds of things that I think really help.
Yeah. That's huge. I've been seeing a more of a shift too with insurance companies where they want to know the quality of life. How does it affect the patient? It's not surprising. It makes a lot of sense. But if that's what's going to help get the patient approved for this medication that they really need, I mean, that's huge. But I love that.
Absolutely.
Yeah, it does take a team. It's so important for everybody to be on the same page when it comes to access and kind of stepping a few steps ahead because these insurance companies change up everything so often and we've got to be prepared to be able to fight back for our patients. If we have everything that we need at our fingertips to fight back and to show them this is why it is necessary for them to get this medication, for you as the provider to have that voice to say, this is my patient. I'm seeing them, I make these decisions with the patient versus letting the insurance dictate what they can and can't be on, I think is so
Right.
important.
I will tell you my little not so secret, Janelle, that to date, if I ask when I get on the phone with that specialty reviewer in a one on one to try to get a med approved for a patient, I always ask them, can I please have your email address to share some photos?
Mm,
My patients know that I'm going to do this. And in fact, my patients will bring in the worst of the worst photos and we'll take a photo of their photo
mhm.
just so I can include it. And the person at the insurance company knows when it was really bad because
Yeah.
that patient thought they needed to take a picture of that flare when it was really bad. To date, when I ask them if I can send photos, I've never had a denial.
Wow. That's
So we
amazing.
all take photos, we all use them.
Mhm.
Don't be afraid to get your patient in on it and tell them what you're going to do. That's something that even my MAs do when they know we're at that point. They're like, you know what, you look really good today, and I'm going to take some photos. But do you have any pictures when it was really bad? Because that might help get it approved.
It's so good. I feel like years ago when they would request that peels are sent by mail. Now mostly everything is fax. It was easier to send those pictures through the mail, and I remember getting so much stuff approved, sending those pictures and things, and now not so much because you're sending a fax, but that's a good tip to get the email. I love that. So,
Absolutely.
what is one thing, that you wish every provider or payer even understood about off-label prescribing?
I think we have to recognize that if we are using something off label as a provider, specifically as an NP or a PA, you really do need to document the why, especially if you're not following the the gold standard therapy or whatever tried and true therapy has been established for years. Explain it. And, it can just be one or two sentences that, really explain the why from a nuanced standpoint, why you would do this. And I think on the payer side, at least in my experience, when we're talking about off label, a good portion of them are oldies but goodies. Like maybe there are indications that don't have an FDA approval. And so we're trying to get something that's really inexpensive and they don't really care. If it is a medicine that's expensive, say you have a patient with maybe severe progressive vitiligo and you want to try an oral JAK inhibitor because they're in pipeline and they might have an approval soon, you're going to have to really argue there. And I will say I've had companies that eventually say yes over the years, and I've had companies that say no.
Mhm.
And then sometimes I'll go through the medical side and really explain the why. And sometimes they'll give me access, especially if it's like a younger child who doesn't meet the age indication.
Do you think that there needs to be more education just in general around access and how to really make sure that our patients are getting the medications that they need, even if it is off label? Because I feel like there's not a lot of conversation around off label.
Yeah, there's some of my favorite lectures, but yes, I agree. More, more, more. We've got to learn, what are it's like the pearls,
Hmm.
like people that are having really good success. And that's what I was asking for in that LinkedIn post. If you're having success with the therapy in a specific situation, share your pearls with everyone else. And I can't think of a better, way to do that, honestly.
Yeah, absolutely. Leigh Ann, it's been such a pleasure talking with you, and your knowledge and the education that you're providing is just is so needed. And I really appreciate everything that you do for your patients and bringing this conversation to light. It's so important to have, but it also is so helpful. There's so much good information that we could really utilize when it comes to knowing how to connect with our providers to make sure that we have the correct documentation, knowing how to go a step beyond to make sure that we're meeting the needs of our patients, I think is so important.
Absolutely. And that's what it's all about.
Yes. Thank you so much.
Thanks, Janelle.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.